the topic is comparing the outcomes of deceased donor and living donor liver retransplantation. All the transplantation are performed in a private transplantation center, liver and kidney in Istanbul. It is one of the hospital of Memorial Hospitals groups. You see the team, and I can pass to the.
We only see the first slide.
Yeah, I passed. In countries with scarcity of cadaveric grafts, such as Turkey, 7 or 8 cadaveric donors per million person per year, patients with graft failures, unfortunately, have an extremely low chance to find a cadaveric graft. In Istanbul, where there is a very low cadaveric graft PMP, more than 95% of liver transplantation are performed with living donor. And in our center, 1,200 liver transplantation, 92% from living donor and 8% from deceased donor were performed between the years 2011 and 2021, January 2021. 32 of these cases were retransplantation. So the rate of retransplantation is 2.7. This rate is very low related to the normal level of retransplantation, which is between 8, 10, or 12%. And these 32 cases of RELT were performed with DDLT, whole for 5 recipient, split for 8 recipient, and LD, living donor, for 19 recipient. Our aim was to determine whether RELT with LDLT and DDLT grafts are comparable, have comparable outcomes. The medical records of 1,200 patients who consulted to the organ transplantation center, to the Istanbul Bahçeli Evler Memorial Hospital for LT between September 2011 and January 2021. After inclusion, 32 RELT patients divided into 3 categories. As whole grafts re-DDLT, split grafts re-DDLT, and re-LDLT for outcome comparison purpose. Indications for RELT were divided into 4 categories. A vascular complication, portal vein thrombosis and hepatic artery thrombosis, chronic rejection, early severe graft dysfunction, biliary complications. Vascular complications and early severe graft dysfunctions were indications for early retransplantation, and the chronic rejection and biliary complications were indications for late-term RELT after 90 days from first LT, and early under 90 days after first LT. So you see here, it's a complex table, but I will reduce it. You see here the indication for first LT. For indication of first LT, before the demographic particularities, there is recipients are older than others. Recipient of whole graft, cadaveric graft, are adults almost, are older than recipients who received split graft and living donor, living grafts. And almost the first liver transplant from living donor, except for transplantation from DDLT. So indication is the classical indication for first LT. There was for autoimmune hepatitis, for viral hepatitis, 3 cryptogenic cirrhosis, and for 8 pediatric patients, cholestatic disease of pediatric patients. Indication for retransplant were 11 chronic rejection and the 3 secondary sclerosing cholangitis for late transplantation, and for early transplantation, so under 90 days, vascular thrombosis, either portal vein and hepatic artery, and for fulminant hepatic failure. Per or post-op outcomes are similar, except there were more, the blood loss is more in patients who received whole grafts. There is a statistical difference, and operation time is longer in re-LDLT groups. And after, according to the hospital stay, ICU stay, and the duration of the mechanical ventilation time, there is no statistical difference between the groups. Postoperative complications are mainly vascular and biliary complications. Biliary complications, vascular complications are 5 portal vein thrombosis and 2 hepatic artery thrombosis. And the vascular complication happened in early period, 5 or 7 vascular complication in less than 90 days after retransplantation. So there are early complication, but before biliary complications are later. 4 or 5 complications occurred after 90 days after retransplantation. This is I resumed this table. In re-DDLT, the occurrences of postoperative complications were as follows. Portal vein thrombosis and acute rejection in less than 14 days. Biliary stricture, there is only one between 3 months and 1 year, and another one after 1 year. In re-LDLT group, the occurrences of postoperative complications were as following. Hepatic artery hepatic artery thrombosis, biliary leakage, and gastrointestinal bleeding, and acute rejection in less than 14 days. Portal vein thrombosis 1, and another one, hepatic artery thrombosis with biliary leakage and biliary stenosis in the first 15 to 90 days. But in summary, vascular complications are earlier than 90 days, and biliary complications are later than 90 days after retransplantation. So the survival analysis, the overall patient survival, rates for 30 days, 30 to 90 days, 90 days to 1 year, and 1 year to 3 years, and after 3 years were 78 71%, 68%, 65%, and 65%. Since we didn't perform secondary transplantation in neither groups, the graft survival rates were equal to patient survival rates. You see here the survival rate according to graft type. The graft type, pardon. And the distribution of the mortality is seen here. We lost the most of the patient. There's 11 mortality on 32 retransplantation, and we lost in 40 days. In 30 days, in first 30 days, 7 of the 11 mortalities. So 7 on 11 mortalities occurred in the first 30 days. And between the 30 to 90 days, there is 2 mortality. And after 90 days to more than 3 years, there is only 2 mortality. So, based on the reality time dependent, there is an error here. Dependent mortality. I couldn't correct this word. Dependent mortality, not survival mortality. Based on the interval time between the primary late liver transplantation and retransplantation, the overall mortality rates for patients who received received a reality in 14 days, 15 to 90 days, 90 to 1 year, and more than 1 year were 57, 50, 0, and 71% respectively. There was no statistically significant difference between reality times in terms of mortality. So there is no difference between reality times in terms of mortality. There was no difference between the times within the groups as well for re-DDLT group and re-LDLT group. However, it is important, this constatation, when the time between the liver transplantation setup as early up to 90 days and late to more than 90 days, there was a significant difference between the early and late RLTs in favor of late RLT. So the RLT performed after 90 days of the first LT have lower mortality than the liver retransplantation performed in the first 90 days after the first liver transplantation. So more it's late liver retransplantation, more is good the survival. You see here a part of inferior mesenteric artery of recipient utilized as interposed arterial graft in the recipient also. Here the common hepatic artery, proper hepatic artery, and the interposed inferior mesenteric artery here, and you see here the right hepatic artery of the graft. And as portal vein, iliac vein graft are utilized as interposed graft, venous interposed graft between the portal vein of the recipient and portal vein of the graft here, you see. And here the harvest of the inferior mesenteric artery in the recipient, you see here abdominal aorta, and the length of the inferior mesenteric artery approximately 3 centimeters, but it was functional for this. And here, in the first image, you see here the only the one orifice of the inferior vena cava correspond to the right hepatic vein IVC anastomosis of the first graft. Okay. There was, as conclusion, this is the last slide. There was a significant difference between the early and late retransplantation, liver transplantation in favor of late reality. So, if the difference time between the first and reality is more than 90 days, the outcomes, the survival is favorable. Conclusively, re-DDLT has shown comparable outcomes to re-DDLT, if not better. These results may encourage performing re-LT with grafts from living donors in patients with indication for re-LT without worrying about low chances of survival. Thank you for your attention.
Thank you, Ibrahim. Question from the floor? Just a quick question, Ibrahim. I think that re-LDLT should have been difficult because by definition it is another donor in the family. In how many cases it was possible and in how many cases this was not possible? Have you any idea of the successful rate of such type of living donation?
It's difficult for the family to give a second living liver from the members of family to the same recipient. So according a second chance to the recipient, and it is more difficult than the results of the transplantation is lower than the first transplantation. So that's but the relation are the family relation in Turkey are very strong. So they can find a second donor, but the rate of reality is 2.7. Why? Because of this reason, it is not the same profile for all the families. So we can, there were some indication for reality, but because of the scarcity of living donor, we couldn't perform reality, and it's for this reason that our rate is 2.7.
Okay, thank you.